Hi, and welcome to the 2021 Focus on Eye Health National Summit. Thank you for joining our event today from locations across the US and the world. I'm Jeff Todd, President and CEO of Prevent Blindness. Through this platform, we're pleased to be able to bring you expert presentations, resources to support your vision work, and opportunities to connect with others. Throughout our 113-year history, we've always been an organization that looks forward. We remain dedicated to preventing blindness and preserving sight, and we elevate that mission through three strategic pillars: educate, advocate, and empower. This past year has shown us the importance of strong public health interventions and addressing the social determinants of health, and we're proud that Prevent Blindness can serve as the convening organization to address these issues on behalf of the vision and eye health of millions of Americans. The Focus on Eye Health National Summit convenes for its 10th year under the theme Our Changing Vision, which celebrates the key advancements that have occurred over the past decade and looks ahead to leading technologies, policies, and social issues that will shape how we approach eye health for the coming decade. This past year has taught us a lot about areas where we can strengthen vision and eye care, so we're excited to host this opportunity to bring together diverse stakeholders to work together to elevate the role for vision across the globe. This event would not be possible without the support of our many sponsors. I'd like to thank our platinum sponsors, Genentech, Horizon Therapeutics, and Pharma, and our gold sponsors, Alcon, Biogen, the Center for Vision and Population Health, the Eyesight Foundation of Alabama, the National Center for Children's Vision and Eye Health, Novartis, Regeneron, and the SIVA Foundation. And thank you to the many silver sponsors for contributions. You'll see their logos across the platform across the next 2 days. We encourage you to take full advantage of our virtual event by attending the presentations in the auditorium, visiting sponsor booths in the exhibit hall, and engaging with other attendees in the lounge. In addition, most of our speakers today will be available for a chat for 30 minutes after their presentations for any attendees who would like to ask further questions. You can access these chats by going to the auditorium and clicking on the link in the session descriptions. Finally, we have prizes available for our attendees who have the most engagement with our event. You can visit the leadership board for more details. The link to each day's presentations will be available at the end of each day at the Focus on Eye Health National Summit website. In addition, you can also access presentations from previous summit events. We encourage you to make this a social event. Links to the Prevent Blindness social media accounts are available in the lounge. Please share this event on social media with your colleagues and contacts. You can also follow everything that is presented at the summit today on Twitter at #iSummit. Thanks to each of you for being here today. It's my wish that you carry what you learn here into your work to strengthen vision and eye health across the country. And now I'm honored to be co-moderating today's sessions with Dr. Kathleen Murphy. Dr. Murphy is the Associate Dean of Inclusivity, Global Health, and Community Engagement, as well as the A.O. Stubblefield Professor of Nursing at the University of Texas Medical Branch. She is a nursing leader with extensive background in family, school, and population health issues, particularly among underserved populations. She's been engaged in public health perspectives on vision and eye health for many years, especially as they relate to children. We are honored to have Kathleen as the chair of the Prevent Blindness Board of Directors. She has a long history with us, as she's been a past chair of both our Public Health and Policy Committee and our National Center for Children's Vision and Eye Health's Advisory Committee, as well as a member of the Board of Directors of Prevent Blindness Texas. You'll have the opportunity to meet Kathleen virtually in our next session. And now, before I introduce our keynote speaker, a few final logistics. Today we'll have a Q&A at the end of most sessions. You can submit your question through the Q&A button at the bottom of the screen. We'll respond to as many questions as time allows. As I mentioned earlier, you will have the opportunity to chat with individual speakers in a chat room as specified in the session description in the auditorium. Finally, after the end of each session, please return to the auditorium to join the next session. And now it is my honor to introduce our first speaker for the day, Dr. Michael Chiang, the Director of the National Eye Institute at the National Institutes of Health. We're excited to have Dr. Chiang provide our keynote presentation, Eliminating Blindness and Improving Quality of Life Through Vision Research. Please welcome Dr. Chiang.
Well, Jeff, thank you so much for the opportunity to come here and present, and really look forward to doing this. I've been in this position at the National Eye Institute now for about seven months, and for me, it's been a process of about learning about the institute and also learning about the NIH overall, and really getting to know the community. And I'm going to share my screen here. In terms of getting to know the community, I've really gotten to appreciate that a lot of this is about communication, and communication is not always that easy. And in that spirit, we've been trying to use social media. We set up this Twitter handle, NEI Director. And if you're on social media, please consider following that. This is not a shameless plug. It's because we're trying to use social media to do things like communicate initiatives and really what's going on with and eye health at the NIH. So what we've been doing in the last 7 months has really been a lot of looking at our mission, looking at our strategic plan, and that's really what I want to talk about here in the next 30 minutes. What we're doing at NIH and at the National Eye Institute. I think the place to begin is that everybody in this meeting is interested in eye and vision research. And the question is, why does our work matter? And I think it matters for a lot of different reasons. And this is just a really good reminder that work in vision has enormous impact on quality of life. Okay, surveys have always shown that blindness is among the conditions that Americans fear the most. And there's a survey here in JAMA Ophthalmology, New York Times article about that the worst thing that can happen is going blind. And so in that sense, I think all of us really do work that matters. When people lose vision, they have trouble with activities of daily living, things like driving, recognizing people, ability to read. And vision, it's not just about reading eye charts and seeing it, it's how we experience the world. And vision is what really links to human emotion. For example, I visited the Grand Canyon for the first time, and what I remember about that is the visual image. When I saw my daughters walk for the first time, take their first steps, I'm never going to forget those, that visual imagery. And when people don't have that, there are risks of things like isolation, depression, accelerated dementia. Okay, when people can't see well, their memory doesn't work as well. And so that's an impact on quality of life. Now, in terms of science, there's enormous broad impact. And the point that I want to make with this is that there are many really seminal innovations that have occurred first in the eye and the visual system. And the reason for that is that the eye is so accessible. You can get to it easily, you can do surgery on it. And when we do clinical research, there are easy outcome measures, okay, things like visual acuity, visual field, that a lot of other fields don't have. And at the National Eye Institute, we are really proud to have supported the work of 8 Nobel Prize winners, starting with Hubel and Wiesel, who did really foundational work in visual neuroscience. Okay, so I think we really do work that matters in the vision field. Now, I want to just break this talk up into 3 parts. And the first part is going to be, where have we been in the past 5 years? And getting to this theme of eye and vision research being ways that we've really innovated in science. Okay, so just a couple examples of really remarkable things. Number 1 is going to be ocular imaging. Remarkable work. I got this video and this slide from David Huang and Yali Jia, who were 2 former colleagues in Oregon, who have done some transformative work involving OCT imaging, optical coherence tomography imaging, that has really brought about a revolution in research and clinical care. Now, when I was a resident 20, 25 years ago, I learned a lot of qualitative assessment of the eye. Basically, you'd get a lens, look at the retina, and then qualitatively look at the nuance of the macula, the optic nerve head. And now, because of things like OCT, there are ways that we can quantify this, like never before. You can do three-dimensional volumetric imaging. There are now methods in OCT entry where we can non-invasively look at things like flow and motion within the retina, and really get capillary level resolution that approaches that of histology. Okay, things that we never ever would have imagined 20, 25 years ago. And there's really a lot of potential to generalize this across other fields, looking at structure and function of the eye. Now, from a pure cost perspective, there was this study showing that using imaging and OCT to guide therapy for macular degeneration has saved between $2 and $9 billion for patients and for the government. Okay, so major revolution because of work in ocular imaging that's really generalizing to other fields. So example number 2 I want to highlight is gene therapy. When I started my career as a first-year resident, actually within the first month of my first year of residency, I diagnosed a baby with Leber congenital amaurosis. Okay, so this is a baby where these babies lose vision almost completely. And what I was told at that time, this is 1997, was that I should tell the parents, we can provide supportive care as your child loses vision. And that's sort of a doctor speak for saying, there's really nothing that we can do medically to cure this disease, but we provide supportive care. And we continued saying that to patients. But several years ago, there was an FDA-approved gene therapy, okay, the first in all of medicine for an inherited disease that looked at this mutation, RPE65 mutation that causes Leber congenital amaurosis. And the initial work to identify that a gene, I'm proud to say, was done at the National Eye Institute by somebody, Mike Redmond, here. And it was really Gene Bennett and Al McGuire and their team at the University of Pennsylvania that did a lot of the seminal work in terms of translating this to precision medicine, gene therapy to target this mutation. And these videos take my breath away every single time. This is a motility maze. And this is before gene therapy with somebody who's lost their vision from Leber congenital amaurosis. And you'll see that this patient is she's supposed to follow the arrows and go around these obstacles. And this is after retinal surgery to insert this gene. And you'll see the before versus the after. That before, she can't go through, is really slow, can't get through the obstacles. And afterwards, she can go through it, really easily. And just never would have imagined this 20, 25 years ago. Okay, it would have been science fiction. Okay, so major advances in gene therapy and really all of regenerative medicine. At the NEI, we've had a so-called Audacious Goals initiative over the past 8 years that's taken this into new directions. Cell-based therapies, and now moving into things like gene editing and cell reprogramming. Okay, so example number 2 is gene therapy and regenerative medicine. And example number 3 is what we'll call artificial intelligence. A huge amount of work going on in all of medicine over the past few years. And I captured this tweet about 1.5 years ago from Eric Topol. And it says, of all the medical specialties, most people think radiology is leading the artificial intelligence movement, but it's really ophthalmology so far. And why is that? Well, we've got so much data and it's accessible. Things like retinal images, clinical data, electronic health record data, and we capture that data and we take care of patients. And the first FDA cleared autonomous artificial intelligence system in any field of medicine was in diabetic retinopathy. And it was done by Michael Abramoff and his collaborators at the University of Iowa. Okay. And that's made its way into real world care now, okay, vision screening, largely in rural and urban areas. And a group at Google Health has done remarkable work in terms of knowledge discovery by doing artificial intelligence on retinal images that gives us insight on systemic health. And here's an example from their work. They've taken these retinal images and trained neural networks to identify, well, how old is the patient that retinal image came from. And you'll see here they can do it within plus or minus a few years. And for most ophthalmologists, that's not that surprising, that we can generally look at a retina and tell did it come from an older patient or a younger patient. Now maybe we can't do it within plus or minus 3 years. But another thing that they did really captured a lot of people's imaginations, that they trained deep learning systems to identify, did that retina come from a male patient or a female patient? And they taught these systems to do that with almost complete accuracy. And so, none of us can look at a retina and tell, did that retina come from a male patient or a female patient? And so really, maybe there is potential for artificial intelligence to teach us things in terms of knowledge discovery from looking at data that's somehow encoded in the pixels here. Okay, and so there's another thing I wanted to highlight is that a group at Moorfields Eye Hospital in the UK has done some really, really impressive work looking at AMD progression, macular degeneration progression, by looking at largely OCT images, so combination of imaging and artificial intelligence. So major work involving artificial intelligence, and we'll come back and talk a little bit more about that. Okay, so we've really done enormous innovation within the eye. The second thing that I want to highlight is, well, what's unique about this point in time, and what are the opportunities, and what's our mission at the National Eye Institute? Okay, so if I look at the current climate, around the world in 2021, there are a few observations I want to make. Number one is that there are enormous advances in science, technology, and computing power, okay, like never before. And those things really create unprecedented opportunities for things like knowledge discovery, for translating that basic science knowledge into clinical care, and for public health. Okay. And the other thing about 2021 is that this pandemic has exposed, I would say, a lot of underlying health disparities and health inequities in this country. Okay, and I think that I'm coming to an increasing recognition that all of the scientific advances, okay, like the ones that we showed on the previous slides, or even things that are less sophisticated than gene therapy, they're not really that useful, or not really completely useful unless they're accessible to the entire population. Okay, so we've got to tackle that problem. And with things like this pandemic and things like vaccination, I think that I've really had an increasing recognition of the importance of how important it is to effectively communicate scientific findings to the general public. Okay, so this is what we're dealing with in 2021. And when I started this position 7 months ago, one of the first things that we did is we really looked at, what is the mission of the National Eye Institute? And it turns out that we have a charter. It was established in 1968 when the NAI was founded. And we realized that it hadn't been updated since then. And so we worked with a lot of, what I'd call internal stakeholders and external stakeholders to try to revise that mission statement based on the current climate. And this is not yet on our website, but it's been approved by our council. So it'll be up relatively soon. But I just want to go through it because I really want this mission statement to inform the way that we at the NEI think about the landscape and how we define what we do. So our mission is to eliminate vision loss and improve quality of life through vision research. Now, how do we do that? We drive innovative research to understand the eye and the visual system, to prevent and treat disease, and to expand opportunities for people who are blind or who need visual rehabilitation. Okay, the next thing we do is that we foster collaboration. And I'm going to talk a lot about that during this talk. Next thing is that we recruit, inspire, and train a talented and diverse new generation of people to basically strengthen our workforce. And the last thing that we do is that we educate. And who do we educate? Providers, scientists, policymakers, and the general public about advances in research and how they impact health and quality of life. Okay, so again, it is really my hope that this mission is going to define, really the way that we think about, how we approach problem solving. So eliminate vision loss and improve quality of life through research. Okay. So the last part of this talk, what I want to do is focus on where we're heading. Now, what we've been going through is a strategic planning process. And where we are right now with it is that, this has taken up a lot of my attention during the past 7 months. And it was started by Santa Tuminia, in the year before I got here. And, what's happened is that we've put it out for public comment and gotten a lot of really useful feedback, including some from Jeff Todd and the Prevent Blindness group. And we're putting that together. And what we're targeting is to really release this in fall 2021. And what I want to do in just the remaining time is highlight a few of the things from our strategic plan that I think are going to be of interest to this audience. So to talk about strategic plan, just a quick note about the way that we currently organize the National Eye Institute's extramural programs. In other words, our research that goes out to the external world, when people apply for grants. For example, our budget at the NEI is $835 million per year, and about 85% of it goes to extramural research. So what's on this slide? And we organize that anatomically. So we've got a retina portfolio, a cornea portfolio, lens and cataract, glaucoma/optic neuropathy, strabismus, amblyopia, and visual processing, which basically means neuroscience and eye movements, and low vision and rehabilitation. Okay, so this is how we organize things now. In this strategic plan, we are trying to take more of a cross-cutting methodological approach. Okay, so these core 6 areas, okay, retina, cornea, and the anatomy of the eye on the previous slide, they're not going away. They're still the way that we organize, the way that we think about our portfolio. But we've identified 7 cross-cutting methodologies: genetics, neuroscience, immunology, regenerative medicine, data science, quality of life, and health disparities. With the rationale that these cut across all these anatomic domains. And we want to make sure that we're identifying all the potential opportunities for innovation and knowledge discovery. Okay, so what I want to do is go through 3 of these: data science, quality of life, and public health and health disparities. And just to give you a sense of what we're interested in and where we're headed at the NEI. So the first area is data science that I want to talk about. And that means, for example, things like big data and artificial intelligence. And, why is this important? Well, think about the question, what is the one tool that every single scientist and clinician in this country uses? Okay, now if you're a doctor, it is not a stethoscope, it's not an ophthalmoscope, it's a computer and computing resources. Now, because of the way things are now, there is unprecedented access to large-scale data sets. And so, we can just do things that we couldn't have imagined, even 10 years ago. And so the thing about data science is that, these methodologies, okay, things like artificial intelligence, analytics, they can apply to all areas of science. If you're a biologist, versus if you study imaging, versus if you're a clinical researcher, versus if you're a public health researcher, you take these data science methodologies and you apply them to your domain, okay, from biological systems to population-based health. And so because of that, these methodologies are really, really broadly applicable. So what is changing in data science, and why is this such a hot topic right now? Well, we've alluded to a lot of these issues. There are exponential advances in computing power. And this has gone on for decades, that the power and the speed of these devices and of memory has increased exponentially and continues to do so, okay, so-called Moore's law. At the same time, these artificial intelligence and machine learning methods, number one, we're better at doing it than we ever have been. And number two, when we've got more data and when we've got more computing power, it's just a good, it fits perfectly for artificial intelligence methodologies. And so the old way that we used to think about computing is that you'd take a data set and you'd write an algorithm and you'd put those together and the computer would give you some sort of analysis or some sort of output. And now with these machine learning methods, we're kind of taking that paradigm and flipping it upside down. We're taking these data sets, which are getting larger and larger. Okay, for example, a large set of retinal images. And we're taking those outputs. For example, you get doctors to look at those images and diagnose them. You have severe diabetic retinopathy, moderate diabetic retinopathy, and you're putting all that data in the output into a computer, and the computer is analyzing it and creating the algorithm. In other words, the computer, through these machine learning methods, is learning these complex latent relationships. And that's really at the heart of what I would call this revolution in artificial intelligence and machine learning during the past 5-10 years. And I would point out that these technologies like deep learning and convolutional neural networks, a lot of them had their origins in what I'd call the systems neurobiology of vision. And they were really patterned to mimic how we process visual information in many ways. And so I think that in a lot of ways, vision research it has been pretty fundamental to this revolution in artificial intelligence. I would point out that there's been a lot of examples of successful academic industry collaborations, and I highlighted some of those examples in those earlier slides. But to make all this work, we really need large, well-curated data sets. Okay, really, really important, and that's at the heart of what we're trying to emphasize in this area of emphasis. So what are the opportunities? This slide, we're going to talk about data sharing and data harmonization. And so the question I want to start with here is, if artificial intelligence is so good, why aren't we all doing it now, and why are doctors, still around, doing what we always did? Well, there are major challenges in the generalizability of artificial intelligence study findings. Okay, these systems have been shown to do things like identify severe diabetic retinopathy or tell whether you have a male retina or a female retina. But oftentimes, these data sets to do these studies come from a fairly small number of large research centers, and they're often fairly homogeneous because of that. Because they're research data, they're often very well characterized and cleaned. And real world data is often much lower quality than research data. Okay, at the same time, in the vision field, we use many, many different types of cameras, OCT machines, other imaging devices, and there's often significant heterogeneity among those devices. In general, you cannot easily take an artificial intelligence system trained on one device and translate it to another machine. Now, at the same time, we obviously have many, many different races and populations of people. And these findings don't always generalize among different races and populations. And so it's very, very important to come up with systems that work across the entire population. Now, more broadly, I would say that in the field of medicine and vision research, we often have very small clinical trials, single center studies that address really similar problems. Okay, this is not just an artificial intelligence problem. This is a general clinical research problem. And these clinical trials are often done by very smart people, but they're underpowered often. And if the data are not harmonized, in other words, if they don't collect the exact same type of data with the same parameters, you can't share data across different clinical trials. And there are major, major lost opportunities here. Okay. And so along those lines, another opportunity here is that in the vision field, we've got what I'd call cross-modal data. Okay, we collect imaging data, we collect electronic health record data, genomic data, metabolomic data, a lot of other so-called omics data. And so we can analyze data across those different modalities. And there are very, very few other specialties that can get such robust data across that whole spectrum of data types. And so, but overall, to make this work, we've got to have incentives for data sharing and also collaboration. And we've got to harmonize data so that we're comparing sort of apples and apples among different sites. And so these are huge opportunities that we're really focusing on at the NEI. And along those lines, one of the things that we've become really interested in is imaging standards. Now, in the vision field, a lot of our data, we've got a lot of these machines, okay, devices, and these devices, for reasons that we've talked about, are generating more and more quantitative data than ever before. And so that's huge opportunities. But the problem is that a lot of these data are locked in what I'd call proprietary systems, and you can't really get the data out of those systems very easily. And so if you're a doctor taking care of patients, one example is that I used to work in Oregon, and at our institute in Oregon, major eye institute in this country, we maintain two image management systems, okay, basically two image databases for real world clinical care, because we couldn't get all the devices to talk to each other and to all those image management systems. And one company's device worked better with another company's image which with that company's image management system, for example. And that's a challenge for clinical care when all your data is not in the same place. And there are also enormous barriers from a research perspective to doing research involving image data. So for example, another Oregon anecdote, I used to work with an informatics PhD student who was trying to do some artificial intelligence studies looking at glaucoma, looking at OCT data and visual field data. And he spent a year, okay, really, really good PhD student, and couldn't get the quantitative data out of those devices. Okay, and we've looked at, we've tried to get image data into large scale data sets, really, really tough to do, okay, for these reasons. And so I think we have opportunities to try to help these devices talk better to each other. And I think that research is going to benefit and clinical care is going to benefit because of that. Okay, so another opportunity. So area number 2 is what I'll call quality of life. Now, we've highlighted that our mission includes things like improving quality of life and expanding opportunities for people with blindness or low vision. Now, how many people are involved? The latest study that we could find, JAMA Ophthalmology, Flaxman et al., 2021, 7 million Americans with low vision and over 1 million Americans with blindness. And globally, 250 million patients in these categories. And the other thing that we know is that as the population ages, the prevalence of low vision and blindness increases actually exponentially. Okay, so this is age, and this is prevalence of vision loss. And here we're 50, 60, and 70 here. And so our population is getting older, and this is getting to be a bigger and bigger problem. Meanwhile, there's this increasing recognition that for people who do clinical research and quality improvement, there's growing importance to incorporate patient perspectives in health-related quality of life assessments. So people who are doing clinical trial need outcome measures, and more and more importance on things like patient-reported outcomes, not only for clinical trials, but also for just real-world quality measurement. Okay, is my doctor doing a good job? Well, let's ask the patient and see what they think. So that's a lot of this motivation. Now, the field of vision rehabilitation is really meant to address this. And traditional vision rehabilitation focuses on things like, well, if a patient can't see well, let's make it bigger, okay, with a magnifier or a screen device that makes it bigger. Or let's use assistive technologies. If a patient's using a computer and they can't see the screen, well, let's read the screen and translate it to audio output. Okay, now, because of these advances in technology and innovation, I think that we're beginning to move beyond that. For example, there's some really, really amazing work involving retinal prosthetics. A lot of this has been led by Chiang and his group at University of Southern California, USC. And their device is basically a video camera that's built into a pair of eyeglasses that the patient wears. And that connects to a video processing unit here. and the video processing unit analyzes the data and transmits it wirelessly to an array of electrodes that's basically surgically implanted onto the retina. And it basically stimulates the retina based on what the video unit is seeing in the outside world, and that's giving the patient's perception. And so, what's the science that you need to make that happen? Okay, I listened to a fascinating conference that was sponsored by Mark Kamayan and the USC group here. Well, we need things in drug delivery, implants of bioelectronic devices, research like nanotechnology, wearable electronics, bioengineering scaffolds to get these arrays into the retina, for example. And so the point that I want to make from this is that these are major opportunities for innovation across disciplines. In this case, it's scientists and engineers working with doctors. And the work that they're doing here is really innovative from a scientific perspective. In other words, it's captivating the engineers, and it's also really innovative from an eye research perspective. And the other thing is that we're taking this work and we're translating it into the real world. Okay, and I got this video from Mark Kamayan. Basically, 5-10 years ago, they actually developed the first FDA-approved implanted retinal prosthetic. And this happens to be for a patient with retinitis pigmentosa who hadn't been able to bowl for 20 years. But and I think
just like that. Oh my God.
So
oh my.
Just again, 20 years ago when I started my training, this would have been another one of those things that would be science fiction. So I think that the other opportunities in this area are going to be things like what I'll call rehabilitation for brain-based visual impairment. As a pediatric ophthalmologist, I've spent 20 years taking care of patients, and cerebral visual impairment, cortical visual impairment, is a major cause of childhood blindness. And we often don't always know what to do with these patients and how best to help them. Okay, what causes CVI? What are the associations? Prematurity, perinatal brain damage, often things like oxygen deprivation, and what's wrong with these vision for these children? Well, low vision, peripheral vision deficits, but often what I'll call higher order vision deficits, okay, visual attention, recognition, and we really need to better understand what the neural basis is of diseases like cerebral visual impairment, and how they differ from things like traumatic brain injury and stroke, and how we might be able to exchange knowledge across fields. From a doctoring perspective, we just need better tools and guidelines for diagnosing and classifying and for managing these patients. And from a rehabilitation perspective, I think there's increasing evidence that people with brain-based impairments like CVI or stroke or traumatic brain injury, versus ocular impairment, for example, macular degeneration, there seem to be differing rehabilitation needs. And this is an area that's really ripe for interdisciplinary collaboration. People who do imaging, people who do neuroscience, physical therapy, occupational therapy, education. And so I hope this is something that we can do more and more of. In terms of other opportunities for quality of life, we live in a world that's increasingly reliant on computing devices and mobile devices, and those devices have visual cues. Now, people who can't see well, it's just harder, to use these devices. And James Coughlin, who's at the Smith Kettlewell Eye Research Institute, sent me this video of some work that they're doing involving mobile apps, where you've got cameras and sensors, and they're developing basically artificial intelligence and computer vision tools to identify objects in the environment and essentially create auditory GPS. And so this is James's video here.
So I need to make sure the camera is seeing what's around me so it can give me good directions.
Left. Straight. Right. Straight. Left. Your destination is through a door on the right.
So, a lot of overlap with this type of quality of life research with, what are the factors associated with successful education, employment for people with visual impairments, and how can we translate this into best practices and develop better devices like this that'll help people. Okay, so my last item, I'm just going to finish up pretty quickly here, is public health and health disparities. Vision loss and blindness are among the leading cause of disability in the US. Everybody here knows that. There's enormous public health and economic burden of visual loss. And we also know that there are major gaps in care for people in what I'll call high-risk groups, the elderly, children, women, certain races, people who live in rural and urban underserved communities. And there are a lot of public health organizations that are working on this. And we at the NEI are becoming interested in, have been interested in, really interested in, how do we work with these organizations, again, to make scientific advances more accessible to the entire population? And one possibility is telehealth, remote delivery of eye care, and disease surveillance, health promotion. And we know that our world is becoming increasingly virtual, and that affects the way that we get our entertainment, that we communicate with each other, that we're meeting via Zoom instead of in person. And more and more, especially with this pandemic, people are getting healthcare, via telehealth, as opposed to the way that we used to always do it. But we need to do a lot more evaluation studies involving the efficacy. Does it work? Does telehealth work? Is it acceptable? Is it cost effective? And how can we develop new models for remote care that are based on, for example, telehealth? And how can we better understand the social determinants that are relevant to vision disease and eye care? And how can we integrate that data into electronic systems for analysis? And so the last couple of slides here, that we are really more and more interested than ever before in recruiting a talented and diverse new generation to the NEI to strengthen our vision workforce. And why is that? Well, I've tried to highlight that there are major benefits of interdisciplinary research, that when you get people from different academic backgrounds to work together, that's when you make these major innovations. And from an identity diversity perspective, when you get teams with different kinds of people and different types of thinkers, there's good evidence that those heterogeneous teams outperform homogeneous teams in terms of problem solving and innovation. And there are a lot of benefits here, for the overall clinical research enterprise. And for what I would say is the basic science enterprise. And this is not something that NEI can do alone. We need to work with the entire community to do this. And I hope that's going to involve many of the people in this conference. And so my very last slide here is that, I think we all do work that matters. And I hope that we can really appreciate the transformative impact of eliminating vision loss and improving quality of life. I've tried to highlight a lot of these examples, and really what we're trying to do to drive innovative research, to foster collaboration, and to recruit a talented and a diverse new generation. Look for that strategic plan coming out in fall 2021. And I'm really excited to work with all the community about what we can do together to promote innovation in the future. So thank you very much.
Thank you so much, Chiang. That was fascinating. Really appreciated and enjoyed listening to that. There have been quite a few questions coming in though, so I'd like to jump into right now while we have some time remaining. One of the questions that came through is really broader than the NEI. It's about the National Institutes of Health in general. Have you seen similar shifts to cross-cutting areas of emphasis across other NIH institutes, especially in regards to data science and public health? And has the NEI strategic planning in this direction encouraged development of relationships across different governmental agencies, other non-governmental organizations?
Yeah, Jeff, great question. Mitch Brinks, I see that this is something you asked. Great question. So the answer is yes, that we are more, I think that there's more and more of a recognition in our world that we have disparities and that population health is just more on people's radar screens than ever before. And one of the things that I'd really like to do is to be able to work with other groups within the NIH and also just around this country overall to try to make that happen. Because the fact of the matter is that the pipeline starts with basic science, goes to translate into clinical care, and then goes to populations. And so I don't think we can have one of those without the other. And so the challenge is really how can we best connect those dots and work together to be able to do that.
Great, thank you. And there are a few questions here that really focus on low vision and those who are living with blindness. I know historically that a relatively small percentage of the NEI's attention has gone to this, but could you expand a bit on your vision for NEI's efforts to address quality of life issues for those who are experiencing vision loss or blindness right now?
Yeah. Jeff, this is a great question. I'm looking at some of these questions in the chat box and trying to synthesize. So I'll try to put together something that addresses what you asked and what I'm seeing from these chat box questions. Number one, the reason we do what we do is that we want to help people. And people come across a whole spectrum. For people who have good vision, we want to keep them at having good vision. So that means preventing vision loss. For people who have minor or treatable disease, we want to develop the best ways to treat them. And for people who have severe vision loss, this is some of these examples that we focus on quality of life. We want to develop better ways that they can become accessible, develop better methods for accessibility. And so I view quality of life as being a whole spectrum of issues. The second issue is that there are a lot of groups that work with, for example, assistive technologies. There is some research, for example, funded by foundations, National Science Foundation, private industry, and I'd love to be able to find ways to work together with them to best be able to do that.
Thank you. I find this question pretty fascinating. I'd be curious on your answer. Carol Torres says, absolutely fantastic talk. Glad I fit this into my schedule. How can we publish good, strong, negative data? Such papers are usually rejected, but much can be learned from these failures. Any thoughts on that?
Carol, that is a great question. I don't, I think that gets to a broader issue of data sharing. So I think that there's two issues. One of them is how can we better share data? And the second is how can we best identify what's most important so that we're not overcome by so much data that we don't know what to do with it. And I think that's something that I've been trying to think through. And I don't have a very easy answer because I think that's a great point about negative results, but people can easily become overwhelmed with negative results. And I would love to think through the best way to balance data sharing, getting things out there with making things as useful as possible for people. And so love to think more about that and continue that conversation. Jeff, it looks like you're frozen here. And assuming that I'm not frozen, I'm going to look through some of these questions. I see a question from Ann Coleman. Does research need to be hypothesis driven with AI? And Ann, great question. I think that you can have hypothesis-driven research and hypothesis-generating research, and AI and large-scale data sets create potential for hypothesis-generating research, like we've never really been able to do before. Like I'm seeing a question here. Is there a concern that utilizing AI for screenings can weaken the patient-provider relationship? And I think that's a great question. And I do have some or a lot of concern about that. What I hope is that AI can actually take some of the burden off of clinicians to do things that clinicians don't necessarily need to do. But I hope that it allows clinicians to focus on things that they can uniquely add, as what their unique added value is. So, for example, maybe doctors and healthcare providers should be focusing on actually talking to patients instead of just copy pasting notes in the chart, which we often do right now. And if that's one of the consequences of AI, I think that would be awesome for healthcare. Now, the problem is that healthcare providers have to realize that, have to really identify and cultivate what those skills are. And I think that's going to be at the intersection of technology, doctoring, and also just medical education. So really, really important question.